diagnosis, family history of anxiety or depression, and war zone exposure. Now, females who left the military are more likely than males to come home with PTSD because of the sexual assault that occurs on base. And some secondary risk factors are branch of service, age, and ethnic group. In terms of age, younger people were more likely to come home with PTSD than those soldiers who were older, which may be a function of the social support groups that they have to come home to. Branch of service was somewhat predictive because in some branches you have more exposure. And in terms of ethnic group, there seemed to be a difference between groups, which may be a function of how open certain cultures are to normalizing traumatic events. For example, Hispanic soldiers who came home were twice as likely than white soldiers to face PTSD in the long run. For assessment tools, there's 4 pre-screen questionnaires that the National Center for PTSD recommends. There's the primary care PTSD screen for DSM-5, which is a 5-item questionnaire that asks soldiers whether they've experienced a traumatic event, if they're still experiencing nightmares, if they're avoiding situations which remind them of incidents that they experienced at war, if they've ever felt constantly on guard or watchful or easily startled, and if they feel guilty or are unable to stop blaming themselves or others for events that occurred. There's 3 other questionnaires that are similar. The SPAN, they ask them if they, in the past week, felt startled or physically upset or angry or numb. The SPRINT asks them if they've experienced intrusive thoughts, avoidance, if they felt numb or aroused. So once a soldier has taken one of those pre-screen questionnaires and they have a positive result, that will cause them to move on to the clinician-administered tests. There are a few, but the clinician-administered PTSD scale for DSM-5 is kind of known as the gold standard, and it asks them to respond to 30 questions on the PTSD symptom scale to get that final diagnosis and to move on to treatment.
So, prevalence. The prevalence of PTSD in military populations varies. It can vary with time, gender, race, age, and service era. PTSD rates increased in military populations between 2004 and 2012. PTSD diagnoses in deployed military personnel is up to 8%, and diagnoses in those military personnel who have not been deployed, it is up to 5.2%. PTSD is common both among active military members and veterans, and PTSD diagnoses overall can be seen more in women in the military versus men.
So soldiers have a number of treatment options when they return home. They may pursue medical treatment in either a VA hospital or TRICARE facility, which is also sponsored by the military, or they may seek treatment in an outside facility like their general practice hospital or a mental health clinic. As far as the treatment prescriptions available, it's advised that they pursue an evidence-based trauma-focused therapy. For example, you might look into a cognitive restructuring approach. One of the modalities of which they mention is cognitive processing therapy. You might offer an exposure approach, like prolonged exposure therapy. And there's a number of others, like eye movement desensitization reprocessing. In addition, you may be prescribed some pharmaceuticals, such as selective serotonin reuptake inhibitors or selective norepinephrine reuptake inhibitors, which are both classed as antidepressants.
Gaps and barriers to service. So one barrier to service is stigma. This can be both public stigma and self-stigma. Military personnel may avoid treatment due to this stigma. Also, they may have a fear of being judged or criticized due to a diagnosis. Oftentimes, stigma is attached to a mental health diagnosis. Another barrier to service is comorbidity. Comorbidity of PTSD and other mental health problems is very common among those in the military, and they may need to seek treatment for more than just PTSD, so it could be challenging to find an adequate intervention that covers every aspect of a client's needs. And finally, accessibility to services. Active military members may not have time to access treatment. There are little to no PTSD resources for deployed military personnel, and accessibility to services is also an issue for veterans. It may be challenging for them to get an appointment, and also not every PTSD intervention is available at every Veterans Affairs service location. So the gaps and barriers to service also have impacts for social workers. Social workers need to be aware of the barriers in PTSD services and try to overcome them as best as they can. There is a need for better services for those military members and veterans diagnosed with PTSD. As I just stated, comorbidity of PTSD and other mental health disorders is common among military personnel, so it's necessary for social workers to be sure that the intervention is appropriate based on the specific needs of the client. And finally, social workers should draw on social support. Social support is a really big reason why people seek help for PTSD, and many military personnel wish that their social supports would be more involved in their interventions.